Now we're going to talk about another important topic, which is behavioral health. It's something that we've touched on at this conference for a number of years. I know it's a top priority. It's something continues to come up in our needs assessment. So with that, to get us started, I'd like to introduce Mike Phillips. Mike, for those who don't know Mike, is Senior Director of Patient Advocacy and Housing with Jewish Family Service of San Diego. So Mike, if I can turn it over to you.
Hello, everybody. I'm going to go ahead and sit down. Hi. So I'm going to go ahead and introduce our guests and then do a broad overview, and then we're going to hear from our guests. Then I'm going to ask some questions, and then you all are going to ask some questions. It's a lot that's going to happen in a really short amount of time. So let's get started. So our panelists today, in the order of my list, we have Stephanie Welch, who is the Deputy Secretary of Behavioral Health for California Health and Human Services Agency. I should probably move to this end. Let's do that. And we have Dr. Luke Bergman, who is the Director of Behavioral Health Services for the County of San Diego Health and Human Services Agency. Woot, woot. And we have Marissa Barond, who is the Executive Director of the McAllister Institute and Chair of AdSpa. So I'm very excited to be here. Thank you for the introduction. I want to note that my role as patient advocate is a county-funded program funded by the County of San Diego. And so what we're going to do here today is I want to do just a very brief, broad overview of some of the concepts, and then you're going to hear from the individuals who are really making all this happen. So some of you may know this already. I'll try to be brief, 2 minutes maybe. There's a lot that is happening policy-wise in behavioral health. This is probably the biggest change we've seen in decades. So the 3 main points I'll hit, and there are others that will maybe come up. One, of course, is Care Court or the Care Act. This is a process by which certain number of individuals with very specific criteria and schizophrenia or other psychotic disorders, individuals can refer to the court and see if a care plan or care agreement can be designed to provide services for these individuals. That's a big one. That one is happening now. It's been implemented here in San Diego County on October 2nd. We are one of the first 6 counties in the cohort. LA will be next month. The second piece of this puzzle is something called SB 43 that you may or may not have been following. SB 43 changes the definition of grave disability under the Lanham and Petra Short Act. So previously, someone could be detained pursuant to danger to self, danger to others, or grave disability. Grave disability was defined as someone who was, due to a mental disorder, unable to provide for food, clothing, and shelter. This new bill, which is now going to be law, it is law, it'll start either on January 1st or as late as January 1st, 2026, will expand that definition to those same things, food, clothing, shelter, but it will also add in the inability to provide for personal safety and the inability to provide for medically necessary care, and even more broadly, which is why I'm glad we have this panel today, it will open that up to SUD, drug and alcohol criteria. So this will be the first time this tool can be used for drug and alcohol. That definition will follow through all the different LPS holds, and including LPS conservatorship. So there's a lot to unpack there. Lastly, Proposition 1, which will be on the ballot in March, will, if passed, modernize the MHSA Act, and it will divert funding to housing and SUD. Super important, needed services, but it's important to note that it will take those monies out of the existing pot of mental health service dollars. It will also put $6.48 billion general obligation bonds on the map to create additional housing, which was going to be unlocked, but apparently locked is now on the table right before the governor signed it. So with that, I will hand it over to our panelists to have a few minutes to talk about anything they want to talk about. And then we'll get to some questions. You first.
But really, it's an honor to be here today as a community-based organization, to be in this room of such dynamo folks who are looking at not just behavioral health, but our systems that serve people. It's exciting, and I think many of us in the behavioral health world are understanding that the collection of changes that are coming are probably the biggest that we will see in our careers. And the piece that I would add that was not included is CalAIM fiscal reform. When providers have the way that they are paid changed, I think so too do incentives, so too the systems And I think really looking at what sort of levels of care are incentivized and how we are coming together to make sure that, as we're engaging folks, whether voluntarily or involuntarily, that we have a system that is ready to catch them and support them. And the last piece I would add is I think we're very quick when we speak about behavioral health to often, and especially substance use disorders, to assume that there's just 100% of folks with a substance use disorder have no interest in care. And I think what we see at our programs is over 57% of the people that we serve actually are self-referred. And so I think one of the biggest and most important conversations that we can have is, why is it then that 94% of people who need help never get it? And it may not be that it's an involuntary or voluntary basis, and maybe instead it's a system that we need to look at.
Great. Stephanie?
Okay, oh, my mic works. Well, thanks for having me. It's nice to be here. It was important for me to come because I actually see our hospital providers as a really core part of our behavioral health continuum. I'm a social worker by training. I've been doing this work for almost 25 years, which really is hard to say. But this is by far, I've been in this position for a little over 3 years. I came in kind of at the peak of the beginning of COVID. And it has been nonstop. I'm not going to sugarcoat that in any way. And I think one of the main questions I get all the time, or kind of pushback, I think, towards the administration is, you guys are doing too much, you're doing too much, you've got to slow down, you've got to slow down. And what I can say from my experience is that I don't think we'll ever have an administration and a legislature who have made this such a priority. It is an opportune moment to take what we can get. I've worked in the previous administration, I've worked at the county level, I've worked at the nonprofit level, and I'd have to say that this is fundamentally a realization of the things that we knew worked 20 years ago. First episode psychosis is a great example. We studied it over 20 years ago in other countries, but we were never able to scale it. At all. And so now in one of our proposals, we will be making it part of our Medi-Cal program. So I think it's rapid change, and change is hard, and it's iterative, and it's a lot of work. I think a lot of us have missed vacations and had very long nights. I'm sure you have. But I do think we've got 2 more years with this administration to realize and start to implement some of the changes we've wanted to do for over a couple of decades. And so I'm really excited to be here and really excited to think through how our hospital system partners can help us do better for people and to try to reach people who we haven't been able to reach before. And so I'm really here. Obviously, I brought my notes because I was afraid you guys have a lot of questions. There's a lot going on in this space. My job is to be the primary behavioral health provider to our secretary, and really to be the go-between between the wants and wishes of the governor's office and our 12 departments and our 5 offices. And so I'm really excited to be here, and I look forward to the questions.
Thank you. Luke?
Thanks so much. You can hear me okay? Okay, great. That is a good thing for the moment, at least. So it's a lot. I think that's the sort of first thing to acknowledge, and it's and I think for many of us who are kind of working closer to the ground and sort of meant to be kind of carrying and making real some of the the larger and heady aspirations of the administration. It just feels like a shit ton all at once. And I'm just trying to be really on brand with all of you here. So, but I would say on balance, I'm extremely grateful to be working in this job in this moment. I mean, I have to say I didn't, decide to become the behavioral health director in San Diego to sort of be like a steward of stasis. It's been our interest down here to make really substantial change to a system that, that I have felt and that my leadership team in behavioral health services at the county has felt needs to be dramatically changed. And so it's wonderful to see the administration acknowledging that. It's wonderful to be working in partnership with a network of community-based organizations that are eager, I think, also to make what has been problematic about the system better. I think there is some question, right, about are these things that, that Mike Phillips just enumerated, are these the things that are going to make it what we think it should be? Or is there some slippage? And I think that's, that is kind of the thing we need to spend, I think, not just time here talking about, but that's going to be a thing that we need to spend time talking about over time. I would just say kind of at the highest level, we in behavioral health services at the county have been deeply committed to trying to sort of progress the further integration of behavioral health care into mainstream healthcare. Before holding this job, I was AVP over behavioral health at New York City's public hospital system, and that was sort of like my North Star in that work, and that really continues to be my North Star in this work. That, of course, means that this is a really important group of people for me to be engaging with, right? This is where there is, maybe the most opportunity to kind of further that work. And so I think we need to be thinking about how do these things further that. Some of them, the one that Marissa just mentioned, payment reform, right? We're moving from cost reimbursement to like fee for service. Oh my God, welcome to the 21st century in behavioral health care, right? The 21st century and all of its like terribly shitty payment structures. That's like a huge moment for us and a huge opportunity to actually kind of become more integrated in the work that we do. And so I'm excited about that, even though it is, a baby step, I think, in the directions that we're needing to go. The deeper question, and I'll stop here, Mike, I promise, is around the payment structures through which behavioral health is managed in this state by local government situated mental health plans. And that can get real technical real quick, but that really is I think, where we have the best opportunity to make the most and most deep progress in our work. It's important for us to be thinking always about kind of opportunities to be more integrated as instances of sort of operational threading, but we also have to be thinking more deeply about the deeper payment structures that determine so much of our work. And I'm hopeful that some of what the administration is pushing will help accelerate those efforts as well.
Thank you, Luke. We've got a series of questions that I have prepared, and I want you all to be thinking about your own questions. We're going to do our best to stay on time and give you that opportunity. And these questions are directed at any of the panelists or all of the panelists. I think for me, I want to start, given the specific audience, given the changes that are happening and are on the way, I imagine this room is thinking, how can we help, but also what is going to be the expectation on the hospital community? How are they going to be affected by all of these processes to the extent that we can speak to them?
I'll go first. I don't know if I have a lot to say in terms of this, some of the specifics on the second part of the question, but I do think that, as I mentioned in my opening remarks, we really need to have more communication. Obviously, if folks are ending up, whether they be in your emergency departments or they're on admin days at acute hospitals, we just need to know. I mean, I think that this is, like I said, I've been doing this for a really long time. And so knowing the data, having to have conversations about what's really happening on the ground is really helpful. That's why it was really hard for me during COVID because I spent most of my career trying to get out of Sacramento and see what's actually happening, which is one of the reasons why I'm down here. And I'm going to spend some time with Luke over the next couple of days because we can't be building things in, and not have a good sense of whether or not whatever we came up with is going to work in terms of implementation. So I would say communication is key. I also think partnership is key. I know we're going to have some questions later, but like I said at the beginning, people have acute crises and they need to go to a hospital. And they need to get intensive treatment for their behavioral health conditions. They also need to have a warm handoff to ongoing care so that they don't come back to your hospital untreated. And so we really need to take a look at how do we create that partnership, how do we improve that communication between the systems, because at Health and Human Services, we also have the Department of Managed Healthcare. So that's our regulatory body over all of our employer-based and commercial plans. So we're not just overseeing and trying to think about the impact to the publicly funded system. We're thinking about everybody. And I think everybody's care needs to improve. And I want to also acknowledge that we have some infrastructure challenges, but we are making progress. I can't say enough, and I know there's a question later, so I'll leave some of the specifics to then. But we're going to need all of your help, and I really appreciate, I came in when the previous speaker was just taking off, and we still have incredible stigma and incredible discrimination towards this population. It is not going to be easy to build community-based residential placements. It's not even going to be easy to build a large facility where people can get care. It never has been. And I really hope that our hospital partners can be our champions to stand up for what I would consider one of the most marginalized and discriminated groups of people, which are people who are experiencing behavioral health challenges. So I also hope that we can partner in that, because I think we're really going to be moving into implementation. I mean, I was looking, obviously reviewing a lot of things on the plane on the way down this morning and looking at timelines, and we're really starting to hit the road. And with especially many of the things that we were mentioning with CalAIM that are starting to actually fire up. I can't say that so much with our behavioral health infrastructure program. It is an infrastructure program, but we do have hundreds of new social work slots to build out our workforce. We're starting to see some of the things that we started 3 years ago actually materializing. And it's not going to be easy, and we'll need your help in championing these services to be available in communities.
Did you want to add anything, Luke?
Sure. I mean, at the highest level, I guess I would say and kind of first by just acknowledging and amplifying what Stephanie said about partnership. Like, the partnership has to be deeper. It has to be sort of the thing that we focus on. We can't do this with a marginalized behavioral health system that isn't part of the mainstream healthcare system. And so I guess I would want to, just at the highest level say, even though this is the hospital, is this the hospital association meeting? It is, right? I would want us to sort of generally reframe it as the Health System Association meeting, and to sort of really, encourage all of you working in the institutional settings where you work to think about how to sort of broaden the work that you do in and around behavioral health, so that you're not thinking about your institutional situations as the piece of the continuum that is only meant to address people in moments of greatest crisis in this very kind of specific institutional and operational setting. But rather to think about yourselves as healthcare systems that may in fact work in much broader ways to address what is, like, let's appreciate this, a chronic illness or set of chronic illnesses. And in ways that may in fact be profoundly to your advantage as hospitals, right? So, and I think that's the key. If we can think about the work that we are doing as broader than acute care, I think that gives us the most opportunity to develop operational models that will have the most advantage to you all as hospitals with bottom lines, and in the context of other, sort of legislative actions and stuff that's going to make your lives really, really challenging, just with respect to bottom line penciling out.
Marissa, any thoughts? Okay. So for the next question, let's talk about Care Court, Care Act for a minute, and acknowledging that this has been a lot of putting this together, and that we're in the very early days of implementation. To the extent that the initial 6 counties in the first cohort have seen a moderate initial responses, if you agree that that's the case, with respect to the number of referrals to Care Court, what should we make of this initial response? And I think, Luke, I think you alluded to this a little bit. Is there a population that is still in need of assistance that Care Court is missing? And what is our plan to address that need? And then lastly, how will we know whether Care Act is working?
Can I go first? Because CARE Act is my little baby.
Please.
So I do, sorry. You know, obviously, this was something that we were very close to, and agency has a particular responsibility to provide oversight to the ongoing implementation of the CARE Act. So I can share with you, while I don't have data after November 2nd, we get batches of data every 2 weeks. We have about 80 petitions. That could be significantly more at this point. We're very pleased with that number, very pleased. And even better is that only 3 of those petitions so far, at least in that batch, were dismissed at prima facie. And why that's important is because we were very thoughtful in how we designed the process. We did not want to have frivolous petitions. We did not want people petitioning when there was no way that they were ever going to be potentially considered for care. This is an incredibly tailored program for a very small number of people. And when I think about the 12 different initiatives that we have and the literally $12 billion that we've put out in different programs, this is one that's really, really very, very laser focused. And so the fact that we haven't had this, I know I've read a few articles that people are like questioning, why aren't there more? We weren't intending to have more. And I think we're doing something completely new and different. This is a civil court process. It also is a process that doesn't, part of the conversation around care that doesn't get talked about as much is it really is about holding systems accountable, which we've never used the court in that way to do. And so starting small and strategic and being focused on our most vulnerable individuals, I think was a wise choice. And we'll continue to really want to advocate for that to be our laser focused in these early implementation days. I don't have any concerns that we won't know that it works or doesn't work. I just shared with you, I get data every 2 weeks. Now, it's not validated, we haven't produced a report, this, that, and the other, but I would share with you that we have 3 different layers of accountability. Probably at the one that would provide the most insight as to whether or not this works, if we would ever consider expanding it to other populations, would be our independent evaluation. We have a preliminary report that's due after the first 3 years and a final report after 5 years. And I think we're really excited to work with our contractor, which we'll be able to announce next month, on what are the questions? Like, how do we make sure that we're also capturing information about all the people who go off the ramp on a voluntary program? And then, frankly, if they go into voluntary services, do they actually get what they needed? These are really important questions. For our folks who do go through the CARE Act process, did they feel like it helped them? Did they retain their housing? I'm really excited about having the opportunity to actually have an independent evaluation, a research-based evaluation on this. I actually think that you guys might be doing some of your own research too. And then also we have our annual reporting to the legislature. So we're being held accountable every single year to a core set of data, and I hear complaints from my counties all the time. It is a 100+ page data dictionary. We are collecting a lot of information because this is new and we want to get it right and we want to learn from it. And then lastly, we have our CARE Act Working Group, which is a public stakeholder process of a group of folks who represent, in many cases, people who were absolutely opposed to this. We wanted them to be part of our working group, we wanted them to be our implementation partners, and we wanted them to have an opportunity in a public forum to hold us accountable to what we were trying to achieve. So, sorry, I got really excited about it. But I think the last thing I'll say about CARE, and then I'll let you talk about it, and I really don't want to talk about Prop 1 because I can't, so this is my moment to be really talkative. But I think now I can't remember what I was going to say, darn it. I really honestly can't remember. Okay.
It had to do with care.
I know that part.
Luke, why don't you jump in and then
You saved me on
as
this
soon
one.
as you remember, then.
It'll definitely come
Interrupt.
back
Yeah,
to me.
feel
Don't
very
worry.
confident. Well, so I would, again, kind of underscore some of what Stephanie has just said. We have been saying all along to whomever would listen that our expectations for this program are modest. And I've, in some instances, been a little bit pointed about how it feels like maybe that hasn't been the public discourse generally, you know, from some significant places and people. For anybody who watches 60 Minutes, that would be resonant. And that's been, you know, the dissonance between what this thing is, and I have to say that, like, you know, Stephanie has been I think has been a steadfast steward of this program and has had clarity throughout about like the scale at which this thing would actually work well. So there's been consistency there, but there really has been some incredible discordance in the public discourse about this. So that I think informing things like the question that our dear Mike Phillips asked, which is about who this might be missing. Right, like, I mean, if you understand the sort of intended modesty of this program, maybe you wouldn't ask that question. You would ask, like, is that very specific group of people that this is supposed to be, you know, helping? Is it helping them? The folks whom we would maybe think this is missing, of course, outnumber those for whom it is targeted by, you know, many, many fathoms. I will say, being sort of in the weeds of, you know, of its implementation, that we are feeling good about also how it is, you know, rolling out. The numbers are, you know, modest. San Diego County has been, I think, relative to other of the pilot counties, very active and I would say highly productive of petitions. And we are, I mean, a clinical team that is within my department takes this work very seriously, takes the opportunity to do better clinically by the people who flow into it very, very seriously. And we're, you know, I think, again, it's very, very early days, but we're very happy with how it's beginning to roll. We're particularly happy with, and I think this isn't a thing, Stephanie, you may have thoughts about this, but this isn't a thing that all counties enjoy to the extent that San Diego County does. There's a lot of, just from jump, alignment between how sort of the kind of, you know, clinical operators in this space are working with the juridical folks. There's just a really nice alignment between court and kind of clinical leadership and spaces and how we approach this.
I did remember my comment, but I think, you know, and I'll be quick about it. If you want to hear about all the different things we're doing in the behavioral health space, you probably have to come to the symposium next month when we come as an administration and talk about our 12 different initiatives. But you ask a question, shouldn't this be for somebody else? And I would challenge back, that's what we have other things for. You know, why we're doing work in CalAIM, to really make sure there's a no wrong door approach, to scale up evidence-based practices, to do things that actually help people get control of their lives again, like implement supportive employment, to provide transitional rent to folks. So I guess that's really my answer to that. CARE is for a very specific population right now. We have a lot of people we need to serve and definitely serve them a whole lot better. And that's what for some of our other initiatives are for.
Marissa.
So I think one of the things that we may actually get out of Care Court is a few lessons that we as providers and as people in the community may have known, but may actually start to tell the story and to share it with the state and to share it with the county, is a question of network adequacy. And when I was thinking of an analogy, and I was thinking, you know, if I'm starving, but I have a shellfish allergy, and you offer me shellfish as my only option for food, can we conclude that I don't want food or that food will not help my hunger? I don't think that's the case. And so I think a lot of the perceptions that we have of folks who are in an involuntary position is often a matter of we haven't had the services in the community to really meet a person where they are and to provide the meal of their dreams, or, you know, the food that really will satiate the hunger. And as so many hospitals in here, I think what we're going to see here in San Diego is that the lack of subacute services, the space between what I do and what you do, is probably where we're missing a lot of folks.
Now, that's a perfect transition to the next question when you speak about network adequacy. So back to SB 43 again, which widens the net. So as we widen the net of who can be detained and brought into facilities, specifically LPS facilities at this point, what is the expectation of how an already strained system of care is going to be able to address this influx? And then how are we going to address detaining individuals with a severe substance disorder and then taking them to facilities that may or may not provide that level of care, that needed care? Who wants to start?
Stephanie does. Oh, no?
Oh, and if you want me to. I mean, I think, so it has passed, and there is a significant responsibility on the counties to implement this. I mean, as the way in which the legislation is drafted. I think we deeply recognize that there are people who are really at grave risk of very serious harm, and that the conservatorship process has not necessarily been able to reach those individuals. But what I would say, and what I think is the pattern of what many of the things are that this administration has done so far, is, and it is by far the kind of beaming light from at least my boss, the secretary, is we do not want people to be in restrictive conservatorships or any kind of institutional setting. I mean, really at the heart of care was wanting to make sure that we weren't running around trying to quote unquote solve the IST crisis, and instead actually figure out how to help people before they entered our system, frankly, either through a horrible traumatizing crisis at your emergency department, or even worse, the jail. I spent much of my career working in that space, trying to prevent people from having their first experience actually getting any kind of treatment through incarceration. And even in our journeys around the state with the governor, listening to peers and families of their experiences while we were designing care, I would say half of the people, if not the majority, had spent substantial time incarcerated, and it was their first experience getting any kind of treatment or help. And so I think we still continue to want to say that our guiding light is to figure out how to help people before they're that sick that they need conservatorship. And for those individuals who are on conservatorship, how do we step them down from conservatorship? And I just want to underscore how much we agree that the lack of subacute options for people, I can't even, I mean, in our behavioral health needs assessment that we published a couple years ago as kind of a guiding light for our infrastructure program, there are whole deserts in our state, maybe not necessarily in this very large county, but deserts in this state with absolutely no SUD services whatsoever. We have counties that have no adolescent services at all in the entire county. They're driving hundreds of miles to get help for their children. And so I think we still need to really be focused on, building those resources and thinking about what can we do to provide better care so that people can be in the least restrictive settings as possible.
Stephanie, I think this audience would deeply sympathize with an emphasis on a paucity of step-down options out of inpatient, right? Yeah, right. Reading the room correctly? I think I've talked with some of you before. So that, we are the second largest county in the state, of course. This is a massive issue, for us as the behavioral health continuum. That I think folks in this room kind of feel, pun acknowledge, the pain of that more acutely than other parties, because you struggle so desperately to get people whom you have given care to into places where they will do best ongoing, and those places don't exist. And so we are working, mighty hard, I would say, in behavioral health services and then health and human services generally at the county to build up this capacity. We've done this thing called the Optimal Care Pathways model that sort of specifies, oh my God, we need 142% more board and care, and we need, close to 70% more subacute just for complex patients. So we're seeing and able to articulate more clearly kind of what some of those gaps are. The data work that we've done to sort of arrive at those numbers has not really accounted for substance use disorder. We're engaged in that work presently and sort of doing a kind of, what we call optimal care pathways 2.0 to really understand what the incredible prevalence of substance use disorder, right? I mean, it's just like quite something. What that will mean for what we have to build in order to address the, the question that Marissa very judiciously raised. And I think that SB 43, I mean, the sort of only way that I can, kind of like continue to function in the context of all of this stuff going on, inclusive of SB 43, is to see it as a real opportunity, an opportunity for us to see more clearly what that delta is. And I think we're, just in imagining it, we're beginning to sort of, things are beginning to percolate. And I think SB 43 is creating a space where we can actually, I mean, and I'm like thinking of specific people in this room, lots of you, with whom I think we can have now more focused conversations about like the categorical absence of inpatient withdrawal management in the county of San Diego, for example, and which is, I know, a sort of regional artifact in a way, but it's also like, for goodness sake, something that we should probably have really serious conversations about in the context of SB 43, just in the context of any serious effort to address substance use disorder. I think, the other thing I would just want to emphasize is that so much of the work that's coming down the pike, and here this might be a segue to Prop 1, though I'm not suggesting that because I don't want Stephanie to talk anymore. But some of what we have to somehow reckon with in the context of things like SB 43 is like that we need more resources. Not the reconfiguration of present resources, but just more, net, many, many more. I mean, it is like a fact, whatever the kind of etiology of that, it is a fact that the overwhelming preponderance of people with substance use disorder never, ever get care for it. Yeah. And if we want to sort of do better around that, we can't do it with a kind of, like budget neutral approach in the work that we do in substance use disorder. And that's a thing that we'll all, I think, have to press on. I mean, and that's I would say, an area of, kind of happy common interest among all of us in this room.
Marissa?
Well, where to begin?
Big one for her.
I think that it's maybe important to start with the basics, and I hope you'll follow me just through a little bit of technicality here. But the world in which I work and which other substance use disorder providers work is called the Drug Medi-Cal Organized Delivery System. So here in San Diego, we use, and across the state, we use the American Society of Addiction Medicine criteria. And one of the things that I have been doing and trying to figure out in my head is when we do those assessments and someone meets the definition of unable to care for their medical needs, they are no longer eligible for our community-based services. So what do we do when that person is presenting in your emergency department and that bed is not there? I can tell you what happens. Sometimes they do get connected to community-based care, and often what happens is we send them back to the emergency department because we do not have medical staff on board to be able to determine their safety. And it is an awful process. For a provider, yes. For an emergency department, yes. But for the person involved, to have to be cycled between systems, we are doing such a disservice. And so I think when we're looking at SB 43, I don't think we have to wait to learn what we need, because I think hospitals are seeing their impacted emergency rooms. I think they are seeing the administrative bed days because there's no place to send someone who can't care for their activities of daily living. And I think we have to talk more honestly about what I do and what our programs and what community-based providers can do and what hospitals can really provide, and what the heck do we do for the missing middle in very short order.
And that's another perfect segue. So I want to ask a question that you may have just answered, or we may not even want to answer, but I want to ask it because I know it's real in this room, because I've had hospital staff and administrators call me and ask it, is from the hospital perspective, and I'm not speaking for the hospital, but I've received these calls, to the extent that we have a massive or even modest influx of individuals brought in pursuant to SB 43, we are going to have to discontinue those holds because there is just no more room. What are we going to do about that? And I just kind of maybe want to just leave that hang there unless somebody wants to answer it, because I don't know that we have that answer. I think the idea being that we've increased the net as to who we can bring people in for care, but we don't necessarily have the adequacy yet to provide that care. Should we have done it the other way, or should we use this as an opportunity to make the best of it?
I mean, so just to say, I certainly agree with Marissa's point that like some of this shit's visible already to us, right? But not necessarily to all of us. And there's a difference between things being visible and there sort of being like the coalescing of, you know, kind of political and institutional interest to actually make the changes required at this kind of scale. And I think that is an opportunity that we have with SB 43 that makes it, you know, that makes this moment importantly distinct from all moments previous to it. I mean, that, you know, what it sort of feels like we will have is very likely many more people. I mean, all your emergency departments are already overrun with people with substance use disorder, right? Right? That's already happening. So we would anticipate those numbers would very likely increase, right? There will be very strong incentives for agencies to be delivering you additional people. And so I just don't see how we can't see or wouldn't imagine that that's going to happen. So we have to be thinking then, don't we, about like, well, is this a critical time intervention opportunity? Is this is this an opportunity not just to sort of like, you know, kind of manage flow best we can? Like it has to be an opportunity to connect more people. It has to be. You know, especially given the fact that we know 94% of people with substance disorder don't ever get connected to care. We have to embrace it in that way. You know, that means that like we will have to do more as the, you know, as the MHP that oversees the drug medical organized delivery system. It means that health systems will have to sort of be working with us in what will have to be novel ways. I think it's, hearkening back to the speaker just before us, it is so frigging important in this moment, though, that we don't start pointing at one another and emphasizing really who should be doing what, because we all have to do work differently in this space. And the time to like begin doing that is right frigging now. That's what I'm saying.
Can I add something? I know it'll probably be it's not immediate, but I have to call into question like someone materializing in your hospital room on a hold is still not the best way to do things. And so I think we have to question, like, why are we writing so many holds? Why is it that the holds get written, the person comes to your hospital, but then they really actually don't meet the criteria? Like, we have a lot of work to do to make sure that we're utilizing the tools that we have correctly with good training. I don't necessarily know what some of the there are a lot of problems in this system. I think we will unearth several of them. Another one of our projects at agency is to develop the kind of the statewide rollout of the crisis care continuum and 988 and our mobile crisis. And many of those things are not built. But the best thing actually in that kind of all of that work are the system partners that you just mentioned. Everybody wants to come to the table and have a solution and think about, you know, when are we going to get to the day where a social worker can be deployed to someone's house or even to someone who unfortunately is living unhoused on the street and give them crisis stabilization services right there. And so, I mean, I think we need to build that system. It doesn't exist, but I think there's a real moment in time where people, and I would hope that people would question, you know, writing a hold and sending someone to a hospital or dropping them off at a sobering center, it may not be the best solution. We got to come up with something else.
Marissa?
If I'm trying to be really tangible about some of the activities that we could actually do, I would say having hospitals and community-based providers in a room and having the most frank conversation of our lives about what we can do and what we can't do, and coming up with a very clear agreement of, here are the barriers. Incontinence, we're not going to be able to serve that. What can you do in that brief moment to help us with that? All of these really nitty-gritty discussions about who's presenting, what part of their care can you do so that we as a community-based provider can serve them in a way that will do no harm. And to the extent that sobering centers are a new benefit, I think there's a lot of opportunity to look at the collaboration with emergency departments, as has been done throughout the country. There's opportunities for, alternative destinations wherein someone would never even touch the emergency department and would instead be directed to the sobering center. But what will be those disqualifying criteria? Those are the types of conversations that we'll really have to get in the workflow for and start to understand, if this is what's keeping people out of care, what part of it can I take on? What part of it can you take on? And so forth.
Thank you.
I would just add one thing, kind of in light of Stephanie's question, which I think is very, it's very well considered around, like, should we be writing these holds initially? Like, is that the best thing that we should be doing in the first place? And just sort of noting that the compulsion to write holds will not always be a clinical question. It will not often, in fact, be a question about behavioral health at all, really. It'll be about homelessness. And it will be about the sort of incredibly dicey politics around homelessness at the level of municipalities. And I'm sort of like, in a way, just saying this to Stephanie, but also making sure that everybody's listening. It's, I think, so important that we are transparent about that politics in the context of things like SB 43 and some other initiatives that, that we all, I think, collectively as people working in healthcare can contribute to sort of resisting what is in some quarters becoming kind of dogma about the relationship between behavioral health and homelessness, right? It's not, as it turns out, that behavioral health conditions cause homelessness. It's insufficient housing that causes homelessness, right? And homelessness has obviously an impact on the likelihood of people developing behavioral health conditions. Like, we have to really, I think, anchor with that in this kind of conversation. And so that when we're trying to, I think, suggest that maybe the ways in which, the opportunities that SB 43 presents us, if we're trying to suggest sort of slow your roll about that with a kind of clinical hat on, I think it's so important that we understand the politics behind that, or our, kind of suggestions to slow rolls won't be effective.
And I'd like to thank Luke for saying that, because if I were on the panel myself with my patient rights or civil rights hat on, I'd make exactly that point. The individuals being brought to you are not necessarily going to be brought in for clinical reasons. So I have a bunch more questions, but I'm watching the time and I want to make sure that the audience has an opportunity to ask some questions. So I'd like to turn to the audience if we could. And I think Demetrios is going to help with this portion. And if you don't have any questions, you've got to have questions. But if you don't, I've got more. And they already know what they are, so you should ask them that they don't know what they are.
For real.
Hi, I'm Felipa Rios. I'm the Chief Program Officer for Interfaith. I'd like to know what the role you see recuperative care playing in all this.
Is the question to everybody?
Yeah. To whomever wants to answer it.
Recuperative care.
Pass.
Want to say anything about recuperative care?
No, thank you.
Oh, for goodness sakes.
Well, then you, Luke.
Well, I will say this. I know a brief piece about recuperative care here in San Diego, which is the fact that we have excess capacity and that utilization has gone down since the implementation of CalAIM. Are those fair statements?
I do think that recuperative care can be underutilized and was in the beginning. I mean, our recuperative care is quickly filling up. I do think there is a little bit of a disconnect between being able to get people into a recuperative care bed within a timely fashion But I also think there's a disconnect about getting people prior to going into the emergency room. So there's a lot of chronic health conditions, and there can also be a disconnect between behavioral health and the medical piece, because CalAIM provides support for the medical piece. What we see in our recuperative care is the majority of people who are coming in with a acute medical condition also have some behavioral health concerns, and so we are supporting both of those things. And I also feel that there is, I think what you said, Luke, is wonderful. I mean, homelessness is not caused by someone having mental health, but mental health is exacerbated by a homeless episode. And I do think we could do a better job of avoiding having people be on the street and getting them inside to community settings where we can then work with them to get housed.
Yeah. The thing I guess I would say about recuperative care is that we just cannot forget that it is very transitional. And so when we think about what the continuum needs, right? So recuperative care can be very useful as a way of sort of like managing, a kind of exigent need for, for discharge. But we will see shortly thereafter, that discharge causing other pressure on the continuum that is very problematic, or kind of impacts more broadly on population health that only sort of emerge later. So wonderful, but necessarily only in the context of a broader build out of capacity that is community-based, least restrictive, and offers support for people not just for weeks or months, but for years and years, and really their entire lives. Totally. It's an important bridge, but I just don't want us to lose sight of the fact that it's a bridge to a thing that is right now mostly in this county a nowhere. And so that's a thing I really want us to focus on, is like, and I think, healthcare systems have a kind of a lot of opportunity in this, actually, in sort of thinking about how it is that we can all partner around establishing more capacity for long-term care. I don't know how many people saw the New York Times piece on long-term care for the elderly not too long ago, right? The headline should be "shit show," and kind of that's it. But there are a lot of really important analogs just with respect to the kind of work that we need done in the behavioral health continuum, and in fact sort of a congruent paucity of sensible system-level attention and resources in that kind of work.
This is not specific to recuperative care, but since we're talking also about the connection to homelessness, we have to recognize that we're working with a population that is deeply impoverished, and the cost of living in this state is not keeping pace with things like SSI. And so this is not necessarily a comment about the one thing I'm not supposed to talk about, but I'd have to say there's two major things. One is, to Luke's point, we have an aging population with a set of complex medical, potentially cognitive disabilities and challenges. And I personally think that in the behavioral health space, we're discriminated against because, while we will seek, and we've already submitted our waiver for the IMD exclusion and things like that, there are other systems that help pay for the roof and the operation of a building in the rate. And for us, it's like, no, we're not going to pay for that. We're just going to pay for the services inside. And I feel like that's been discriminatory towards our population. And until we figure out how to solve for that, the core set of folks that we need to care for in the community so they don't become institutionalized, or those settings don't become purely custodial because there's no money left for enriched services, we have to figure out some sort of way to pay for and recognize that it's our responsibility for this population to help pay for them to have a place to live. And so, that's what I would say about that too. And it's not everybody, but it's definitely, we're not being realistic at the large numbers of people that it actually is.
I want to pick up on a thread here. First, thank you all for presenting and talking about some really difficult and interwoven topics. I want to pick up on the piece that I'm hearing about transition and bridge and opportunities and post-acute access to care. I would be remiss if I didn't acknowledge all of the hospitals here who see themselves as more than just an inpatient behavioral health bed, but part of a larger continuum. And part of that continuum is partial hospitalization and intensive outpatient services that outside of drug Medi-Cal are not available to Medi-Cal patients. And as a provider, we have those services for Medicare and for commercial. And when we compare our readmission rates, they are double for Medi-Cal patients because they don't have access to that step-down, high-intensity level service. And that's a challenge. And it's part of the fact that we don't have it in our state plan and because there's costs associated. What can we do to elevate that in a parity opportunity? And I don't mean parity across physical and behavioral, but actually about payers. Every patient, regardless of their coverage, should have access to the care that they need to stabilize. How can we do that? We have some really great policy leaders here in the room. How can we partner with you to do that?
I kind of have to take this back because my understanding is that some of those, it would be on an opt-in basis, but as part of our BH Connect waiver that we submitted a few weeks ago, that there are at least for, I don't know if it's specific to partial hospitalization, but there is one piece of it that's very focused on trying to support inpatient transitions. And so I don't know if you know more about this than I do, but I certainly will. I mean, there's an acknowledgement. We produced a crisis care continuum plan earlier this year that actually lists partial hospitalization as a part of what should be a critical service in a healthy and robust crisis system. So, I mean, maybe we haven't figured out a way to pay for it yet, but we're on record of it being a part of a healthy system. And so thanks for bringing it up. I've heard it before, and I'm going to educate myself about what's in our BH Connect waiver because I am under the impression that there's something there. And again, like all of our waivers, you know, like got to opt in, got to be cost neutral. It's a real challenge. So I think it's something we have to get there.
So IOP is coming on board,
Okay.
and Ellie, it's a great point that you're making, and we are certainly doing like kind of system and continuum planning work that anticipates that these are things that the levels of care that you just noted are ones that we can sustain through the public insurance system.
We have another question over here.
Thank you. Thank you for all the work. I want to echo what you were just saying. I'm the COO from API, and I feel like we've been screaming for a long time that we exist, that we're here, and we treat those kind of patients. We treat the patients that have substance use disorders that are unhoused, and we're uniquely positioned to treat them, but we're not able to. A lot of those folks are Medi-Cal only, and then we're in a position, obviously we can treat in our outpatient programs. We're not allowed to bring them in. And then on the inpatient side, when we have to, a big chunk of our patient population meets those, they're unhoused, they have severe mental illness, they're on the have psychotic spectrum disorders. And then we're hard pressed to try to find placement for them. So they're in our facility for long periods of time. And then there's a paucity of treatment options available in the community if they weren't gonna go to IMDs. So, it's a challenge, and we've been asking to be part of the conversation, and sometimes it feels like there are folks that maybe, I don't know if it's intentional, but we've been asking for a long time, and I think that there's opportunity. So when I hear things like there aren't enough treatment options out there, I would disagree, and I think we need to look around and see how we can better partner.
I would want to add to that as well that within the drug medical organized delivery system, I think we have, how many do we have? 12, 18, probably upwards of 20 outpatient programs that can actually provide intensive outpatient services, which is anywhere from 9 to 19 hours per week. There are a lot of components of it that would look similar to an IOP, and it's confusing because it's also called iOS. So very, very close, and makes it tough when people are trying to navigate a resource to figure out what's the difference. But here's one of the differences. If you are a client, as of today, who has a co-occurring condition, there are a handful of resources, but it would require the person to actually enroll in a mental health program And there is a co-located substance use disorder program that will separately provide them services, and that their data will be entered separately in a different system. It is the same person, it could be under the same roof, and our system is still operating and saying that we provide co-occurring care, and we do have licensed practitioners as part of iOS services, but what we don't have are psychiatrists who are actually helping to actively manage psychotropic medications in a way that is really needed. And I know that behavioral health integration is such a long way off, maybe, but I do 2 years. But I do think that the lessons learned and the resources available with IOP will have to be shared with the iOS providers, that will have to be shared with the specialty mental health when we all realize we're swimming in the same pool, hopefully entering data in the same places. And know it's on the horizon, but for right now it is deeply painful, but there are some resources available.
And I will note that we are at time, unless Demetrio says we are not. I want to keep us on track. We are at time. I want to say, in closing, I want to echo what Marissa said, that I think this is the time for us to roll up our sleeves, get in a room together, and have the very difficult conversations. There's a lot of history here and a lot of frustration and tension, but it's time now to do it. As Luke said, these are going to be opportunities. We have to make them into opportunities. San Diego County has a really good history of doing that, and I hope that we can see that happen across the entire state. I want to thank the panelists for being up here. They're doing a lot of very hard work, and there's a lot of expectations on them. It's not easy to come up here and answer these questions a lot of times, so thank you very much for all of you and all the input and the information that you presented today.
Thank you.